This is the Heartland Daily Podcast.
Hello, ladies and gentlemen, and welcome to the Heartland Daily Podcast, where today we're going to be talking about healthcare as we do a couple of times each month. My name is Anne Marie Schieber. I am the managing editor of Healthcare News, which you can access via the heartland.org website. Joining me once again is Devin Herrick. He is a healthcare economist who is a contributor to the Goodman Institute Healthcare blog. Good to have you back, Devin.
Thanks for having me.
So today we're going to focus on four things, and all really interesting, very relevant. We're going to be hearing a lot of discussion about some of these things because they could develop into larger items, and they would include AI in healthcare and whether AI will actually someday replace doctors. That's kind of a frightening prospect. Tariffs are getting a lot of attention, especially in the biopharmaceutical industry. And we have a lot of things going on there when we try to sell drugs abroad and we import a lot of material. And, you know, our price structure here for drugs is very different from many other countries. And we can talk about why that's the case and how tariffs come into play. And then the third item is an interesting development because states are emboldened to now get involved in some drug regulation. And in this case, allowing the drug ivermectin, which got a lot of attention during COVID, to be sold over the counter. And you're wondering, how can they do that if the FDA hasn't allowed it? So we'll talk about that. And then the last one is a couple of weeks ago, there was a hearing in the House regarding acute care in Medicare. And this is kind of in a crisis point because it's very difficult sometimes to find these services after you're in Medicare and you're in the hospital. And a lot of it has to do with just the system and reimbursements. And there are cases where people cannot get care. So that's an interesting issue that will certainly be coming up, I think, in a lot of discussion in Congress as well in a continued effort. All right, so let's focus on the first thing. Will AI replace doctors in 10 years? Now, Devin, you wrote this blog post because Bill Gates, a name known to many people, was on the talk show circuit because he's pushing a book called Source Code. And he was on the Tonight Show, as you mentioned, and he made a statement saying that he believed that AI will replace doctors, teachers, mental health professionals. We're already seeing a little bit of this going on. There's a ton of healthcare information online. People do a lot of healthcare research. And I imagine, and we see this sometimes in mental health treatment now, where you can work off bots to help guide you in, developing or preserving your mental health. So tell us a little bit about what your thoughts. You're not as optimistic, and I think this is bogus. I think Bill Gates is trying to sell a book, but I think you're kind of down the same path on this.
Yeah. Oh yeah. He's, these are sound bites. He's trying to sell a book. I mean, if you go back and think about it, I've been doing research on internet-based medicine going back. I mean, my dissertation was on patient empowerment and, 20 plus years ago. And I mean, health information on the internet is very popular. When I say very popular, I mean, I've seen all kinds of statistics. I mean, 100 million times a year, 100 million people a year go online. That's an old stat. I forget now. Google says there's I forget how many thousands. So basically, I mean, he's correct that people will be getting more information and hopefully better information. It's not going to replace your doctor. It might help you make better decisions about when to go to a doctor. And your doctor may even, when I say your doctor, I mean, healthcare companies will create decision support software to help your doctor. And hopefully it'll be integrated in such a way that I can go online and I can find that information, and I can and have a doctor send me a prescription or send me
Mhm.
a recommendation. So I mean, it's not going to replace your doctor. It will hopefully help patients know more about their own health care, and it will hopefully boost your doctor's productivity. So I mean, I think that's a good thing. But the
Yeah,
idea that your doctor will go away, well, a doctor is the only profession with a license to practice medicine. They
right.
can't go away. You
Yeah.
know?
And we've heard these predictions years ago when the internet was coming on the scene and the internet was going to take away everything. I worked in the news industry, and that did turn out actually to be the case. It basically destroyed the local news industry, but that wasn't necessarily a bad thing, right? Same thing with book publishing. We have Amazon. There's just so much self development of products. YouTube. You
Mhm.
mentioned this in your blog post that, YouTube did not obliterate television. It just kind of changed it. And I think that's probably going to happen in healthcare. I'll tell you where I would welcome AI in reducing medical mistakes. And we know that's
Mhm.
costing us billions of dollars each year. And even today, you can go in and we say that medicine is an art, right? Everybody is different. And a face to face interaction with somebody who's very educated, knowledgeable, smart, and knows you, I think cannot be replaced by any AI, right? But I think maybe where it could be very useful is to perhaps guide doctors. They're very busy,
Mhm.
and sometimes you could see how medical mistakes happen. It's just the system, sloppiness, whatever. And maybe AI could be a very welcome development in this. But do I think at some point we're not going to have a doctor like a Marcus Welby robot in our homes? I don't think that's ever going to be the case.
Well, yeah, absolutely. I mean, you go in to see your doctor, and of course, that is the ideal. Your doctor's like Marcus Welby. He's known you for your entire life, and has your medical records memorized. Well, that's really not the norm anymore. The norm is you go to see the doctor that you maybe switched to a year or two ago because your health plan doesn't cover, or someone else, or you moved, and that doctor has about 10 minutes, maybe 15 at the most, but really 10 to 15 minutes to read your file, to brush up on what your history is, talk to you, listen to you, give you advice, and then kick you out the door. It'd be nice if that doctor could, instead of having the nurse or the office manager hand your file to him or her, they could get a quick summary, AI summary of, well, what is your health history
Mhm.
in 30 seconds, or two paragraphs. So yeah, I think boosting productivity is where it'll work. But it's not really a good parallel to the news industry because the news industry still exists. It's just the old model where you had to subscribe to a paper no
Mhm.
longer exists. And it
Yeah.
no longer exists because it's hard to compete against free, free as in, you can get news in many cases just for the price of having to see a few ads, banner
Right.
ads or what.
And where I would get really nervous, because you've written about this quite a lot, is the entrance of private equity in medicine, where profit is the number one primary goal, right? And not necessarily patient care. And, years ago, we talked about this because we know we have a physician shortage, and we welcome, licensing reform so we can have many people addressing healthcare issues. But one of the concerns was if we were to open the gates on licensing and allowing like not as well trained or extensively trained health workers like nurse care practitioners. I have nothing against them, but there was a concern that that big hospitals were going to replace many of their physicians with um, less trained medical professionals. And I know doctors are a little concerned about this. I think, they're wonderful because they can do the kinds of things that maybe doctors don't have the time to deal with. And, doctors are highly trained and we should be using them for the absolute most sophisticated problems. And, when they're treating a sore throat, that's something that, maybe a less trained person can handle, and probably even better because they have more time to do it. So I don't know. I think all technology does lead to things that we can't even anticipate. And I'm not against AI, but I don't think it's going to be doom and gloom. And I think people are smart to figure this out. We'll never, ever eliminate human interaction. And I hope that will be the same too for healthcare.
Well, and one area you mentioned, I think there is a lot of promise, and there's already shown promise, and that is mental health counseling. You have to, of course, have a, license or certification or what have you to bill, but that doesn't mean that you can't talk to a chat bot. It's not clear to me, at what point is it informational or quote entertainment when really it's beneficial versus, a chat bot can't write a prescription. But a chat bot apparently can talk to you and talk you through, certain mental health conditions. So, that'll be interesting to see how that rolls out, because that's already happening.
Think about psychiatric care. It's very hard to find a psychiatrist. They are in demand, and psychiatry requires a lot of time, especially if they're doing psychotherapy. And insurance companies don't want to pay for all that time. They just want the doctors, many times they're awarded and incentivized just to write a script. And that would not be the best solution for a lot of people, right? So in that case, I could see where you could have a very useful tool driven by AI to do psychotherapy. I don't think that would be so dangerous. And then maybe have some physician oversight if medication is required. Maybe the AI bot can, maybe indicate where the person might need, let's say, tranquilizer or whatever, antidepressant. And, maybe a physician then can come in and review that with a little more variables and face-to-face interaction. The one last thing I want to mention about this, and then you can wrap it up if you'd like. Studies have shown that the best medical experience is when you have a long-term relationship with one doctor. And that's very hard to do in today's healthcare system with health plans, because now we have networks, they're ever changing. It's possible that you have a great doctor and your health plan now no longer covers that doctor. And this is why direct primary care is so critical, so important, because you can have that relationship. They work outside all of these guardrails, right? I shouldn't say that. They're not restricted by all the barriers that the institutionalized conventional healthcare system has, which is like pre-authorizations, coding, and approvals for this, that, and the other. DPC works independently, no third-party payers. And I belong to one, and I get fantastic care. I don't think I ever go and see my doctor for less than an hour. And the fact that my doctor can have an hour to talk to me is incredible. And they have like 1,000 patients at my particular clinic. So it can be done. And again, humans, we cannot eliminate them, no matter how hard Bill Gates tries to do that.
Well, yeah, I agree. And I think that it's really good to have those options. But at the same time, I realize there are people that can't actually afford direct primary care, and that sometimes they just need a little bit of advice. And, so I think AI stands the potential of covering a broad range of needs from the people that just need, advice about their health, whether to go to the doctor, or how to better manage their care, versus all the way up to maybe a direct primary care clinic that recommends a AI interface where you can find out more information quickly that they think is high quality. So yeah, I think it stands the potential of helping a lot of people with a lot of different needs.
Good. All right. Well, we'll see, I guess. Stay tuned. All right. The second item I want to talk about is tariffs, of course, getting a lot of attention in the news in all industries. And especially, this is really putting some sunshine on what goes on in the pharmaceutical industry because in the US, we have very abundant and very low price generics. 90% of all drugs sold are generics.
Mhm.
And it's beautiful. Like a lot of people, we talk about the incredible price of drugs. And when we're talking about those, we're usually talking about the expensive biologic drugs that may cost, $100,000 a year. And there are many reasons for why that's the case. Generics, though, we have a pretty robust industry. And in places like Canada, they have very expensive generics. But what happens, one of the reasons we have these very high cost biologic cutting edge drugs is because we have to pay for the development of those drugs, which is a very elaborate, expensive process with the Food and Drug Administration, right? And so Europe has, many times socialized medicine and barriers on our our drug prices. So what we end up doing is providing, they, are restricted by how much they can charge for a particular drug. And the drug company wants to do business over there. So they abide by that. But somebody has to make up that difference. And it usually ends up becoming Americans. It's a soft tariff. And I was struck because, Thomas Phillipson wrote this article in the National Review. And he's very pro, like he was very much against the Inflation Reduction Act because it introduced price controls in Medicare. And he thought that was going to be devastating. He's done a lot of studies and research showing how devastating that's going to be in the R&D phase of things. And then you wrote an article kind of explaining, Andy, if you can pop that one up. This was your blog post. Tariffs could boost drug prices and cause some shortages. So that to me is very alarming. So why don't we take it from there, and if you can kind of explain what you were driving at in this post.
Well, President Trump has announced the desire, it's to raise tariffs on pharmaceutical products, and there was a reprieve, so it has not gone into effect yet. But the thing about drugs is there really is not one country that produces one drug and does all the ingredients. Drugs are truly global. You can have an American company making drugs in Europe that has raw ingredients from China that has been processed in India. So having a tariff makes it, quite difficult to figure out who owes what. And it's not clear that it could increase the price of drugs. And in the case of generic drugs, a lot of generic drugs, the ingredients come out of China and they're processed into a drug in India. And the thing about generic drugs is the profit margin is very, very low. And that's a whole story in and of itself. It's not just competition. It's also a lot of the drugs are purchased by group purchasing organizations or pharmaceutical benefit managers, both of which are allowed to give kickbacks, and therefore they can extract very low prices. So if you raise the price of a generic drug, or if you run the risk of making the ingredients more expensive, you could probably see some of these drugs go away, because in some cases, the plants in which they're made are getting old. And it's happened numerous times over the last decade that FDA went into a plant, inspected a plant, and said, "Oh, this is out of compliance. You need to do A, B, C." And the manufacturer says, "Gosh, we can't afford to. Just forget it. We're going to close. We're going to just shut down this assembly line." So, I'm worried that it could raise our prices for generics, but could also impact availability of some generics. And although the same is true of name brands, it's not as likely it'll just raise the price because they already have a high profit margin.
Yeah.
But it's kind of worrisome.
Right. But then again, you have the concern that we might be dependent on one country for a particular ingredient. And if we get into a trade war or some sort of, conflict with that country, namely China, they could restrict it and we could be in big trouble. This came up during COVID, and we lost a lot of trust with China. And this is when discussions started to amp up on whether we needed to start building our domestic manufacturing supply of drug ingredients, which I think is a good thing. You have any thoughts on that?
Well, it's going to be a tall order to do that. Because like I said, you have drug companies all over the world, but that has little correlation to where they're actually made. And oftentimes the raw ingredient comes out of India or China and is processed oftentimes in India and then shipped to maybe Ireland to be stamped into a pill, or maybe even shipped to the U.S. to be stamped into a pill. So it's not just one country; it is a whole host of countries, and tariffs could. I'm not even sure how that would work. If I guess it would involve transfer pricing, which is okay. How much profit is made in India versus China versus Ireland versus the U.S. But what is the true cost? How much should the tariff be? It gets complicated.
Yeah. Then, of course, we have this issue of us subsidizing the world's cutting edge drugs. And I don't know if Trump will have any success in doing that. And let me just read you, because we've been kind of talking about this. John Goodman is the co-publisher of Healthcare News. And I just want to kind of read some of his comments when he saw this article. So he said, this is a bunch of typical Euro mumbo jumbo. Europe is offering 0 tariffs. That's a start, but only on industrial goods. And agriculture is off the table, right? So we can't sell our great agriculture products over in Europe. And what about these non-tariff barriers? And this is where he talked about the pharmaceutical sector. And it mentions in this article, Goodman points out this following line: America invents the majority of the world's new medicines, yet we ran a $117 billion global trade deficit in biopharmaceutical products last year. Foreign price controls are a major reason that America imports so much more than it exports, despite dominating the sector when it comes to research and development. So, what we have here are these European countries that are leeching off American R&D and imposing stringent price controls. They kind of do this too with our tech sector, with our big tech companies, and putting massive restrictions on them. I have 2 daughters who work in that field, who are their job is to mind the regulations in Europe so they can keep their products offered robustly. But what they try to do, it's a way to stymie where America has leadership, which of course is in the tech industry and the biotech industry. And again, it's socialized medicine. And if I were a drug maker, I'd want to expand my sales to wherever, right? And I would probably say yes to the price controls over in Europe. But you have to, you have to get that money back. Otherwise, there's not going to be an incentive to develop drugs. If you cannot make a profit, and we're not talking huge billions of dollars, but it has to be worth somebody's while. And we really can't. That's why the IRA, the Inflation Reduction Act, was so frightening, because we're now putting some of these prices of drugs up for negotiation, which will really be a disincentive for companies to want to get into the R&D business.
Well, there are 2 issues that allow this to happen. When I say this, I'm referring to the different prices charged to the European public health sector, Canadian health sector, even I think Australia, New Zealand, and possibly even Japan. It's called price discrimination, which is a common economic term for charging different prices in different markets. The only way that you can do that is if you have the capability of preventing what's called arbitrage. If I could bypass the higher price in the U.S. by ordering that item from Brazil or Canada or Europe, that's arbitrage. So that circumvents price discrimination. Well, the reason why that companies can sell, cheap in Europe, cheap in Brazil, cheap in Africa, but charge a lot in the U.S. is because of federal law that prevents the reimportation of drugs by anybody except the manufacturer.
Mm-hmm.
So in a roundabout way, it is actually the federal government that is allowing these egregious differences in price to exist.
Yeah.
So, and that's been an argument for as far back as I've been in public policy. That has been a debate in Congress off and on over the years. Is and the reason is, of course, we have to have a way to safeguard the pipeline, but it also is safeguarding profits. So if we were to say relax that regulation, I'm not saying we should, I'm just saying, just for the sake of argument, if we were to relax the regulation to allow reimportation or importation by, firms other than the manufacturer, it would put a lot of pressure on some of those price differences.
Yeah.
And you would probably see the price in the U.S. fall somewhat, and probably see the prices in other countries rise. You would also see some countries, Africa, Brazil, Latin America, do without drugs, and possibly even do, forced licensing. They basically make a copy and say, sorry, but we're going to, we can't afford your price. We're going to make our own, which that's always a risk.
Well, you're right. We, like free market people always respect protecting intellectual property patents, right? That's a good thing to have.
Mm-hmm.
A couple of years ago, and I don't know kind of where things left, but it was during Trump 1 where the discussion of importing drugs from Canada got a lot of attention.
Mm-hmm.
Florida, I think, was the first state to allow that to happen in group programs like Medicaid or whatever. And I recall, I don't know where things are at now, but there were the FDA had to approve this, right? They put some safeguards on it that made it almost kind of worthless. There were just so many hoops that Florida had to go through to purchase drugs from Canada that it really wasn't much of a savings. And, it's just hard to get around because you're right. It's a very sophisticated, a very complicated distribution system. It's not as much as saying, okay, bad guy, you can't charge this price and we're going to restrict, how much you charge this for this drug in this country. It's a little more sophisticated than that. So I don't know what's going to happen. Certainly we'll be watching, and a lot of people will be watching. I hope that we don't interfere with our abundant, robust, generic drug system. Now we can get really good, cheap drugs, and like ivermectin, right? Which is our next topic. So let's dovetail to that because it is somewhat related to what we're talking about. So we have a couple of states, Arkansas and most recently Idaho, have kind of bypassed the FDA and allowed the drug ivermectin to be sold over the counter. Now, ivermectin, of course, got so much attention during COVID, and it was a very effective drug for a lot of people, but it was vilified. And we have found out, we know why that was the case, is because they were trying to push the vaccines. And people were having to go to the black market to get ivermectin. I remember I got a batch and I had to get it from a pharmacy in, another state because the pharmacists were too afraid to distribute it. It got that draconian, that crazy. Well, ivermectin has been around for many years. It's a wonder drug. The inventors won the Nobel Prize, I believe, for inventing it. It was originally designed for, parasites?
Mm-hmm. It truly is a wonder drug. I wrote a report about that several years back, and it was like the conclusion was whether or not you think it works for COVID, it was a wonder drug long before COVID.
Yeah.
I mean, river blindness, all manner of parasitic diseases are treated with it.
Yeah.
And it's funny you say have it over the counter. Well, you can already buy it over the counter, but it's going to be in a tube that says equine use only,
Right.
apple flavor. But,
Now, I think probably, and I've asked you for quotes on this particular topic too, because, when you have a generic drug or a drug that we know could be a wonder drug and the FDA restricts it because, people don't really understand the FDA has to approve a drug for safety and efficacy. Huge hurdles, cost millions and millions of dollars to get those. Now, it goes back to the sunscreen argument, right? We don't have certain sunscreens in this country because nobody wants to go to that expense. If somebody can kind of sponge off your money, you're not going to get a patent on a drug that's already out there. And I think kind of the same thing here with ivermectin. So what do you think is going to happen? We have a very friendly and reform-minded FDA chief now, Marty Makary. He's very new, and we're starting to hear a little bit about what's going on at the FDA. They're going to start restricting these petrochemical food additives, color additives to food. I thought that was just kind of remarkable. That's a big deal. But he may be very open. So maybe these states like Idaho and Arkansas feel like now we have a friendly FDA. Maybe they'll back off and we'll just allow this drug to be sold over the counter and just kind of cross our fingers. Where I think in any other regime, they would have just been taking a huge risk to do it. There would be lawsuits and everything.
Well, of course, I'm a big proponent of having a lot more drugs over the counter. We have more information than ever before. You don't necessarily have to talk to your doctor about every little thing. We can go back to the AI argument even. But the best deal in healthcare is over-the-counter drugs. And, if you look at over-the-counter drugs, you can just count. I forget now. There's something like 700 products over the counter currently that were at one time by prescription only. The price falls by about 97% once a drug has been switched from, like a branded product to over the counter. So it's a great deal. It's the best deal. It's the only good deal pretty much in healthcare. I mean, you could say generic drugs are a good deal, but over the counter are really a good deal. So yes, I really wish the FDA, and it may take Congress, I don't know, that I really wish the FDA would more aggressively move to switch drugs to over the counter. And I really wish the FDA would get the ability, and Congress would probably have to give it to them, to decide what drugs are out there that are safe, effective, and safe enough to be self-administered, to be switched, to be, involuntarily. Because the way it works now is the manufacturer has to petition, like when Claritin was moved over the counter, you had WellPoint sued the FDA trying to force the FDA to move Claritin over the counter, but the FDA was like, well, we don't have that kind of power. It's I forget Sheer Plowing, I forget the name, I think owned the rights, and they did move it to over the counter a year later, and now all the second generation antihistamines are. But yeah, it'd be a great deal. I mean, ivermectin, and add about another 100, 200, 300 candidates to that list.
Right. Well, the other thing too is it also has an impact on prices, right? So when a drug is sold as an RX, it could drive the price up, don't you think? Or not necessarily? Well, there's a patent on that drug, right?
Oh, yeah, it's like 97% difference. I mean, I did some studies over the years, and I found that once a drug moved over the counter, and once 9 months had passed, to the point that other companies could also sell it over the counter in generic form, that the average drop in price was about 95 to 97%. So yeah, that's huge. I mean, it's just incredible how much cheaper. And so you just think of the $100, $200 a month prescription you currently take that is safe, and just multiply by 0.03 and see if that's a better price.
Right. and more people, and there is a barrier when you have to go to a doctor to get an RX. You're not
That's true.
drugs. So you eliminate that cost. I just I don't know kind of what to think about this, and I hope that we do bring more drugs out onto the market and on over the counter. There's also the issue of behind the counter. So if the argument that we don't trust, it's kind of paternalistic. We don't want the public to endanger themselves by taking a drug. We have so many products sold over the counter that can be misused and be lethal, right? You can overdose on Tylenol if you wanted to. I mean, it's kind of crazy thinking. At one point, ibuprofen, for example, wasn't that an RX drug at one point? Look at how available and how cheap it is.
Yeah, back in the what was it, in the late 80s or maybe early 90s is when it was moved to over the counter, along with naproxen and a couple others. But before that, I mean, in my memory, when I was in my early 20s, I recall somebody I knew who got ibuprofen, from a pharmacy, not a prescription. Absolutely.
No one's going to misuse it. There's so much information on the internet. You go in and you Google overuse of ivermectin, or not ivermectin, ibuprofen. And, you're going to find a lot of information about why it probably might not be advisable to take a large quantity of that over a long period of time. It could do some damage to your kidneys or liver, whatever. How there's information out there for people who are really bent. I just don't think, unless you're have a death wish and you don't care. I think most people, I trust people to be intelligent consumers. And I don't worry about that safety component as much as maybe some other people do. But anyway.
Well, and I used to tell the anecdote for years about aspirin. Aspirin is probably the one drug, I shouldn't say the one drug, but is a drug that would never be allowed over the counter today if it was not grandfathered in. Back maybe 15, 20 years ago, there was a statistic published in medical journals that an estimated 16,500 people died annually of bleeding ulcers from overdosing on, not overdosing, but just overuse of aspirin. And it truly is the cause of death, but it's been around so long that we don't think anything about it. I mean, the doctor tells you don't take aspirin repeatedly, go off it ever so often, try Maalox, try other stomach buffers, but we figured it out, and it's far deadlier than probably, I don't know how, many other prescription only drugs because of gastrointestinal bleeding.
Well, I mean, we took it because we didn't have a whole lot of alternatives for pain control.
Right.
So it was used widely and probably not smartly. And now, we have competition, we have alternatives. So, and of course, an abundance of information, consumer information. So that
COX-2 inhibitors.
Yeah.
I mean, that's the better drug. I mean, they found that if you take a COX-2 inhibitor, it is, it's the same pain reliever without inhibiting the protective enzyme for your stomach. They've also found that if you take a proton pump inhibitor with a drug like NSAID drug like Tylenol or ibuprofen, that has the same effect of taking a COX-2 inhibitor. We know a lot more now.
I'm not familiar with COX-2 inhibitors. Is that sold over the counter or what's?
There was one, I think, but I'm not sure. COX-2 inhibitors are the new super NSAIDs that don't harm your stomach, but they're not that new. They're actually pretty old now, but for the longest time, they were very expensive. Vioxx, which of course was taken off the market, was one of those, a COX-2 inhibitor. Okay. And they were very expensive. And I wrote about it years ago where they discovered that if you took like not Pepsid, but if you took Prilosec with ibuprofen or whatever, that it was similar to a COX-2 inhibitor. But the caveat was, well, that was also expensive. Well, it's not anymore.
Well,
Something else is, you talk about ivermectin. If you look at the examples of toxicity of ivermectin, it's almost entirely people that couldn't get ivermectin tablets and went to the horse feed store and bought it over the counter in a tube of paste for a 1,000-pound animal,
right.
and didn't do the math right. So
Yes.
a tablet would actually be a lot safer than having people clandestinely buy it from Tractor Supply.
Right. And, when you go through those alternative channels, you can't be assured of safety or whether it's counterfeit. So, yes, I think more sunshine on these products and putting them out in the open, given all the information that's out there, I think we could make that leap. All right. Last item. There was a hearing recently. I want to pop this article up because I just posted it. So there was a House hearing in Ways and Means Health Subcommittee, and they were talking about acute care for people in Medicare. Now, this is a big industry. If you know anybody in Medicare, elderly person or whatever, they're treated in the hospital. A lot of times they're not ready to go home. They have to go to rehab or whatever. And there is a whole industry pertaining to this. Medicare will pay for it, but increasingly these treatment centers are becoming harder to find. And it's probably because we have some problems with complicated cases and reimbursement, and some of the companies are not making profits. We know, profits shouldn't be vilified. You need profits to keep people in business. But when they are lowballed, and what's in this hearing, what they've discovered, a lot of people testified, is that these companies are afraid to take on very complicated cases because they're not going to be reimbursed. And so they cut corners, and they've got to figure out how to get around this. One of our writers, Kevin Stone, has a really fascinating story. He lives in Texas, all right? A huge state.
Mm-hmm.
Has to drive 3 hours to take his mother. His mother requires ventilation and kidney dialysis. There is one place in Texas that does that because everybody dried up. They just weren't making money. It was costing them too much, and they just don't exist. So I don't know what the solution is here, other than to just maybe, my gosh, going back to HSAs and letting people accumulate usable funds in those accounts so that when they get to that point where they need extra care in their elderly years, they've got those funds and they can pay, what they need to pay and keep those companies working at a profit so that they can stay in business. Do you have any thoughts on this, Devin?
Well, you're actually digging into a very big problem that goes way back. And I mean, it goes so far back that it predates my work in public policy, back to when I worked in a hospital. In the 80s, early 80s, you had these basically fee-for-service in hospitals, to where hospitals were reimbursed for whatever they did. And if grandma stayed for 6 months, they got paid for 6 months. And so to cut the cost of hospital care, Health and Human Services rolled out a program called, the Prospective Payment System. And what that does is that pays a hospital a fixed amount of money for a given diagnosis with some caveats. I mean, there's a little leeway, but it's basically you get a fixed amount of money to fix grandma, whether it takes, 3 days or 3 months, and it hardly varies. So basically, if the patient is really sick and needs a month-long stay, the hospital loses money. And so some smarter hospitals took advantage of a loophole at the time, which is where I come in. The hospital I transferred to was one of the first in the nation to take advantage of this loophole, that if the patient could not get well in time, they could be transferred out, discharged from the big hospital into the rehab center, and where they were cost reimbursed based on a TEFRA limit, i.e.,
Yeah.
we were given money every day on a daily basis for their care until they got well. And it was a loophole of sorts that my old employer took advantage of. And yeah, and we literally had people there for a year.
Yeah.
And they weren't lucrative. It wasn't really high paying. They had to be stable. But well, that has since been that loophole has been closed. And so the problem is what happens if you can't get well in the appropriate amount of time? Well, there's what's known as a continuum of care. That is, in the hospital is for sick people that have a lot of variation in their vital signs. Where they can, you got the ER, you have the acute care, then you have intensive care and so on. Well, then we would move them into the less acute or the post-acute care hospital and finally, when they could be moved out of there, they might go to a nursing home. And then from the nursing home, they might go to home with home care. I mean, there's a whole continuum of care, but designed to save money. The trouble is it doesn't always work well.
Mm.
But what's interesting is traditional Medicare is much worse at it than Medicare Advantage. So if there is, in fact, a solution, it would be, study and make sure you're reimbursing these facilities accurately and correctly, but also see what Medicare Advantage is doing. They seem to be doing it better than Medicare.
Well, that's real interesting. And, for people that don't understand, Medicare Advantage brings a private provider into the mix. Mm-hmm. And so they agree to take care of a person for a certain price based on their risk. And so they're on the hook. They have an incentive to make sure the person gets the best care efficiently. And so they're not going to screw around, and they're going to make sure that things are taken care of properly, quickly, efficiently.
Well, here's the thing about Medicare Advantage. They're on the hook for the cost of caring for a Medicare patient. And if there is a overriding concern, keep them out of the hospital. Do what it takes to keep Medicare patients out of the hospital. If you have to get them in a nursing home temporarily, and people don't realize nursing homes, a lot of what they do is caring for people that are coming out of surgery that can't go home yet. If they need home care, make sure you do home care. If they need skilled nursing, make sure that's available. And it's all about keeping people out of the hyper expensive hospitals. I mean, even if you're not making a profit, make sure you're minimizing your losses by keeping patients out of the hospitals. And it seems that Medicare Advantage is better at that than Medicare, simply because Medicare is not managed. It just pays whatever bills accumulate.
Fee for service, right? Yeah. Mm-hmm. And yes, and there's a lot of waste and inefficiency, and the only problem is Medicare Advantage has been under assault. Mm-hmm. And under the Biden administration, they had made some big changes to that program that made it more unlikely to reach its potential. And the potential is, John Goodman talks about this all the time, the risk adjustment. So they have an incentive to care for the neediest people because they get paid more money. And so now we've reduced those risk categories. And if you could be really sophisticated with this with technology and really be very specific, very targeted about what somebody's risk would be, and that the provider would be compensated accurately to take care of that person.
In fact, that is one of the complaints. I mean, the Democrats tend to say, well, we're tired of all these private companies taking advantage of the risk adjustment mechanism. They send a nurse to the senior citizens home. They do a catalog of everything that's wrong, and sometimes they're getting paid more for a given prognosis that's
Yeah.
not even being treated. Well, okay. I mean, you can debate adjusting the risk adjustment mechanism, but we all acknowledge that if that risk adjustment, there's not going to be, you don't want companies competing by not being willing to treat certain people. The tough cases, we have to have a way to get people to treat, companies,
Yeah.
Medicare Advantage, to accept
Yeah.
the more difficult cases.
Yeah. Well, Medicare is in trouble. And so, there's some big changes that need to happen there. And I don't know what the solution is, but that's a discussion for an entire day, all day. I'm afraid we have run out of time. We will have links to the articles that we've discussed, and be sure to check out healthcare news at heartland.org and the healthcare blog at the Goodman Institute Healthcare blog. Not only just articles, blog posts from Devin, but they will tell you kind of everything that's being posted nationally in healthcare news. So if you want to stay on top of things, it's a great resource. In the meantime, stay well, stay safe. Thank you for tuning in, and we'll be back in a couple of weeks.